All right, wonderful. So good evening, everyone, and good afternoon if it's afternoon where you are or wherever. Good afternoon, good evening. So welcome to today's webinar on behavior change and NCD prevention, or as the title says on the slide, applying behavior change principles to health promotion and NCD advocacy. So thank you for taking the time to join us. We know that you could have been anywhere else. It's after work time. You're probably tired. So we do appreciate you joining us today. My name is Abby Beho. I'm the program director at Lake Health and Wellbeing, which is a public health NGO based in St. Kitts and Nevis. And our work focuses on improving the health and well-being of our local, regional, and online communities. And we do that in a number of ways, through research, through advocacy, through public health interventions, and also through health education events like this. So today's webinar is a collaboration between ourselves and St. George's University through their practicum program. So we've been working with two of their students, Chrisanne Allen and Alexandra Peterman, who have assisted us in organizing this session as part of their practicum. So they've worked very hard on coordinating today's webinar with leadership provided by Jay Robinson, our project assistant, and of course our guest speaker, Dr. Fundira. So the topic of this session was suggested some time ago, quite a while ago, by one of our key partners. And we're really grateful to them for highlighting the need for more guidance on how to utilize behavior change principles to support efforts to prevent and control NCDs. So today we'll explore how this approach can strengthen our awareness and advocacy efforts. So once again, thank you so much for coming. Can I just ask you all to mute your mics as you come in? Really appreciate it. Thank you so much. So without further ado, I'm not going to speak very much. I would like to introduce our guest speaker. Our guest speaker is Dr. Dadirai Fundira, who is a global nutrition and public health specialist with a PhD in international nutrition from Cornell University, and she has over a decade of experience supporting global health and development programs. Dr. Fundira has worked across research and implementation with expertise in nutrition, behavior change communication, monitoring and evaluation, data systems, and evidence to action strategy. She has contributed to work with partners including UNICEF, the World Bank, ICF, the DHS program, USAID partners, and major global health funders supporting multi-country initiatives through technical leadership and analysis and practical tools to strengthen program delivery. So it's my pleasure to hand over to our guest speaker, Dr. Fundira, for her to lead this session. So over to you, and thank you so much, everyone, for joining us.
Thank you, Abby, and thank you, everyone. It is a pleasure to talk to you. I appreciate everyone taking time off work after work to listen to this presentation. And as Abby has said, I have over 10 years experience working with behavior change communication strategies and applying this across health and nutrition, from designing community campaigns, strengthening service delivery across multiple countries. So today I'm hoping in a 60-minute, not 90 minutes, it's 60 minutes webinar, I'm hoping that we keep it simple and we keep it interactive. I ask that you use the chat as frequently as possible so we can all learn from each other's context, and so that by the end you leave with a clear way of understanding different ways of applying behavior change communication principles to your specific areas and areas of interest. So I think just out of interest, if you can use the chart also to test if everyone can use the chart and see what's going on. If you can choose one NCD related behavior that you is either hardest to shift in your setting or that you're most interested. I'll just give it about 30 minutes. I can, unfortunately, okay. If you can just put in the chart, you can put a number, or you can, a number for just like 1 for tobacco use and quitting, or 2 for reducing salt intake, just for interest to gauge whoever is on the call and what areas you all work in. I'm going to try and see if I can see the chart. Okay. I'm seeing a lot of threes. I'm a nutritionist, so I'm biased. That's like one area I'm most interested in and that I work mostly in. I'm sorry, I have like a lot of background noise. I'm hoping that in the next minute that should quiet down. But I apologize for that. Um, okay. I see a lot of threes and fours. Okay, that's good to know. So going into today's talk, the overall goal is to help strengthen the capacity of people working in NGOs, youth advocates, and health educators to apply different behavior change principles to improving the impact of NCD work. And the learning objectives, we hope by the end of this session, we are able to explain core behavior change concepts and why they matter for NCD prevention and control, and compare a few behavior change models and frameworks and identify when to use them. And applying, a simple process, how to diagnose a problem, how to design, how to test, and how to evaluate for a chosen NCD issue. And then use the tools that we have to sort of draft a campaign idea and a basic advocacy ask for improving a specific area. And then finally, just ground everything in ethical standards and safeguards that are important for behavior change communication. So to start,
I'm
with the end in mind.
sorry, Dr. Fundira, we're not seeing your
Sure.
slides.
Oh, you know?
We're not. Sorry.
Oh,
Sorry to interrupt.
I don't know what happened. Okay, sorry. Okay. Can you see them now?
Yes, but they're not in
Okay.
presenter mode yet, but yes. Yeah, okay, perfect.
Are they in presenter mode now?
Yes, they are. Thank you so much. Sorry about that.
Okay. Okay, I'm sorry about that. Maybe when I was looking at the chart, I stopped sharing. I don't know. Um, as I was saying that the overall goal is to strengthen the capacity of hopefully everyone who has interest in this area on how to apply behavior change principles to improve the impact of NCD work. So I'm hoping to explain core behavior change concepts and why they matter for NCD work. Compare behavior change models and frameworks and identify when to use each, and then apply a simple process, how to diagnose, how to design, how to test and evaluate for a chosen NCD issue, and use behavior change tools to, or at least discuss how to use behavior change tools to draft or refine a campaign idea and a basic advocacy ask for a chosen NCD issue. And then ground everything in ethical safeguards. What's important, ethical issues to think about when thinking about behavior change communication strategies or health campaigns. So if you don't have time, this is the full webinar in one slide. So the idea or the core idea is that NCD outcomes are shaped by everyday behaviors, and behaviors are influenced by individual, social, and structural drivers. So behavior change tools can help us design interventions that are more targeted and testable. And I'm showing a simple design chain for designing an NCD intervention or campaign. You start off with your outcome, what exactly you are wanting to address. I've used, say, you want to reduce hypertension complications in a specific demographic. You want to think about what the target behavior is. Is it adults? I don't know. Can you please mute your screens? I don't know if that was a question or that was just someone who hasn't muted their screen. And then think about the target behavior. Adults attend screening and follow up. And then what are the drivers to actually get people to go for that screening? What are they capable of? What are the opportunities? What are the motivations to get people to actually attend screening? And then what interventions, what messages should we use? What services, what nudges, what policies can support this change? And then how do we measure and test that we are actually successfully addressing that specific behavior? And to start with the basics, uh, you know, to get us all aligned, let's start with some simple distinction between what we call outcomes and behavior. So outcomes are what we ultimately want. So that's like the NCD issue or at hand. Like we want to reduce cardiovascular mortality, we want to reduce obesity, we want to reduce anything that you actually want to target. And then behaviors are what people actually do. So that is people getting their blood pressure checked, people, improving their diets, people eating more fruits and vegetables. That's the actual behavior. Or they return for follow-up, or they start their medication. So behavior change work becomes much easier when the behavior is specific, it's observable, and it's actionable. That means that we define it by who does what, where, and when. So I like to think of a quick framing question or a quick behavioral diagnosis ask, which is who needs to do what, when, where, and why. And how do we get people to do things differently? So for example, you can think of, I want to say among overweight and obese adults who are 30 years or older, we want to increase blood pressure screening at least once a month at a clinic by addressing a low perceived risk of hypertension. So this can apply to anything. You can, put in the chart, for the area that you're, like the NCD issue that you are interested in, like among what or who you are in, you want to address this behavior, and where or how you want to address it, and by addressing what key driver. We'll go through how to come up with this simple framing question for in a more practical way. But that's sort of the basis of it all. You need to have a very clear framing question of the behavior that you want to target before you think about, how to do it. And then moving on to behavior change theories. So for the next few slides, I'm going to try and provide a very quick practical overview of behavior change theories, what they are, why they matter, and how to actually use them. The goal is really not to memorize these theories or models, but to know sort of the lens to use to diagnose a problem or a behavior problem, and then design smarter interventions that can actually have a chance to move that behavior. I want to be very clear about why these frameworks matter. They stop us from defaulting to raising awareness, because it's very easy when you're thinking of behavior that people just need to know, but it's not always the case that when they know, people will change behavior. So a behavior change theory is a sort of a tested explanation for why a behavior happens and what factors influence it. It's basically a map of key drivers. It maps the beliefs, the norms, the skills, the environment, and it sort of maps how they connect to the action, which is the behavior. So they are useful because they push us to define what we are targeting and how we expect to change. I think if you've worked in this area, you've seen that people sometimes know what's healthy, they know what they're supposed to do, but behavior doesn't change. That's because behavior usually isn't about just knowledge. It can be affected by people's motivation, their habits, their social norms, access, time, the cost, and the systems and the environment that surround them. So theories give us a structured way to understand what's driving behavior so that we don't just guess, and they help us design interventions that fit the real barrier. So today I'm hoping that we'll cover a few tools. We'll start with the COMBI, or the capability, opportunity, and motivation to behavior model, and then health belief model, theory of planned behavior, social cognitive theory, and then the EAST 2. for behavioral insights. Like I say, the goal is not to memorize them, but to, figure out how to use and when to use each and how to pick one. And this is not an exhaustive list. There are way more frameworks and models that are available, but these are sort of the more classical ones and my go-to when I'm thinking of behavior change. So to start with the Combi, it's my go-to starting point because it's simple and it's very comprehensive. It says behavior happens when people have the capability, the opportunity, and the motivation. So capability can mean knowledge or skills. Opportunity is access to time, resources, supportive environments. And motivation includes beliefs, intentions, emotions, habits. So it's great when problems are multi-level, not just like people don't know, but also what systems support them or don't support them. It's especially good when you need to move from sort of thinking about why is this happening to what should we do about it in a more structured way. If you think about like hypertension, I'm going to talk about hypertension screening as an example throughout the presentation because it's easy to understand. So we can think about how to practically apply this to something. So when you think about hypertension screening, you want people to go in and get their blood pressure checked. What can be the capability? You think knowledge, skills, confidence. It can be people don't know that hypertension can be silent. Opportunity, they could be that, there are long queues when they try go and get their blood pressure checked. It could be that they don't have blood pressure cuffs available. It could be issues around their motivation, fear of, if I go and then I have a high blood pressure, I have to be put on medication and, fear of what that constitutes. And sometimes people can have low perceived risk, like I don't think I'm at risk, this doesn't apply to me. And then moving on to like these three classical theories, the health belief model, the theory of planned behavior, and the sociocognitive theory. So the health belief model is especially useful for prevention behaviors like screening, vaccination, or if you want people to go seek for care early. It focuses on how people perceive risk and value. So things like, do I think I'm at risk? Do I think the consequences of this are serious? Do I believe the action will help? And what barriers do I anticipate? Is it cost? Is it fear? Is it time? What cues push me to act? Do I need reminders? Do I need triggers? And do I feel confident that I can do this? Do I have the self-efficacy? Do I feel like I can actually do this behavior? If uptake is low, if uptake is low because people don't feel threatened or don't see the benefit, the health belief model is a strong lens, right? So you can use it for designing messages for prevention of screening or for identifying belief gaps that can block an action. There might be belief actions that make people not do or not adopt a specific behavior. And using that hypertension example, highlighting that high blood pressure is often silent and screening is the only way to know early, or that knowing early lowers your risk of a serious complication. Attaching that knowledge to health outcomes can help like elevate that risk. And then when you look at the theory of planned behavior, it's more about intention and what shapes that intention. It essentially says intention is influenced by attitudes, subjective norms, and perceived behavioral control. So if a behavior isn't happening, the theory of planned behavior asks, do people think it's worth doing? Do they believe, do people believe do they believe that the people who are important to them will approve? So, and do they feel that they can actually do it? The theory of planned behavior is also useful when norms and social approval are big, right? So, and when people feel that the behavior is hard or is not within their control. Think about behaviors that, that exert social pressure, where people want approval or where people's identity matters. they can be very high intention. It's best when, there's high intention, but follow through is low. And follow through might be affected by all of those social pressures or the need for approval or things around, personal identity. So for the hypertension example, the theory of planned behavior lends to normalizing screening by saying most adults get BP check, like their blood pressure checked at every visit. So highlighting that, people who look like you, people who are, who are adults like you, or people who are in your age, gender category or whatever it is, actually do this. Or if you wait for the right time, it often doesn't happen and risk builds quietly. You want to highlight that there's no right time. You need to do it now. Those are the kind of messaging or messages that lends to the theory of planned behavior. And then finally, the social cognitive theory. This is great when behavior change depends on skills, confidence, and social learning. It emphasizes self-efficacy. Confidence is very central, people believing that I can do it. It highlights, observational learning, like seeing people doing it and copying. People copy what they see others like them doing. Reinforcing the behavior, providing feedback, recognizing rewards, and the environment. This theory also reminds us that behavior and the environment influence each other. So in a community or peer-led work, this would be the social cognitive theory would be a great fit. It's best for skills and confidence building and peer influence, like I said, role models and things like that. It lends to using trusted role models. I felt fine, I checked, I caught it early. Pairing risk with empowerment, a quick check can protect your future. And then just to bring this back a little bit, using that hypertension screening uptake, right? In summary, what I've just said is that frameworks kind of help you diagnose what's driving the behavior, not just the lack of awareness, and helps you prioritize leverage points. What should you change first? What should you focus on first? And help you sort of narrow in and design interventions that match the real barriers and enablers. Whatever theory you're using, it could be the COMBI, it could be the health belief models, the theory of planned behavior, those kind of help you unpack what to prioritize, what to leverage, and how to design an intervention that matches that. And then specify what success looks like, behavior objectives plus your indicators. And it can also help you just document or even explain and communicate your logic or decision making for a specific behavior to your partners or other decision makers, right? So for the hypertension screening example, what a framework can help you review, say, is it capability, is it skills, is it knowledge, is it opportunity, is it time access, is it motivation, belief? Are social norms discouraging screening? Is the clinic flow making screening inconvenient or easy? Do people trust the message or the messenger and the service? One tip I would give is that you can pick one primary framework for diagnosis and then add a second only if it adds clarity or if it makes you change your mind about the way you are going to approach a certain intervention or campaign. And finally, I'm going to talk about the EAST, or the easy, attractive, social, and timely, which sort of provides a behavioral insights lens. So this one essentially says interventions or behavior should be easy, should be attractive, social, and it should be timely. In many interventions programs, people, might not screen, not because they don't care, but because it's inconvenient, it's confusing. It's just, they might not take up a behavior because they don't know how to, or it's not being communicated in a way that's easy for them to understand or attractive enough for them to take it up, or in a way that their peers or the people that they care about will approve. or they don't get the information when they needed it, right? So this framework pushes for simplicity to reduce steps, bring services closer, use clear prompts, make beliefs more salient, leverage norms, and time messages when people are most likely to act. You don't want to tell someone about doing a behavior when the opportunity for them to do it has already passed. It's a very practical way of improving uptake quickly, especially through reminders and things like that. And it's best for when you might have already a system that works well enough, and you just want to do some design tweaks, or maybe uptake was high initially for a specific behavior, and then it drops off, and you would want to tweak the way you are saying things. Maybe you started off with a very good campaign, but then the it wasn't accessible enough, or it wasn't easy enough, and you just want to figure out what's happening, and that can help you design and trick and frame the message in a way that can allow uptake. And so in summary, I talked about this different models. You can use them individually or in combination. They have different strengths and can best fit different situations differently. And a practical approach that I recommend is usually starting with the combi, because it's very comprehensive, and that is if you really just want to start with a very comprehensive way of looking at what's causing this behavior, what can cause people to take up or not take up a specific behavior. Then if the issue is risk perception, it's fear, or I'm fine thinking, you can look at the health belief model. If it's social approval or an identity matter, you can use the theory of planned behavior. Sorry, if the theory, and then if the process is simple, or if you want to just to refine or make a process simpler, then you're looking at the EAST framework. So you can start with that combi, and then use any of these classical theories to sharpen your mechanism or your approach and your messaging, and then apply the EAST to just improve that, make sure everything is easy, accessible, attractive, and you maximize the likelihood of people actually taking up that behavior. So some rules of thumb for choosing what framework to use, right? So start with the kind of problem it is. If your problem looks like you need a clear diagnosis, you don't know a lot about it, you really need to map out the barriers, the enablers, then start with the combi. And then you can pair it with a behavior change wheel. I didn't talk about it, but it help you sort of choose interventions once you've mapped them and you just want to use the combi. And then if your challenge look like it's about low risk, it's low perceived risk, it's about fear, misinformation, or, it has to, why should I do this beliefs, then you can do a health belief model. You can pair that with a combi if you want to also map out those barriers and enablers in a structured way. If it's about social approval, norms, intention, or if it's like, are people like me doing this, does this affect people like me, or dynamics like that matter, then you're looking at the theory of planned behavior, which you can pair with the EAST for like some norms and prompts, and just making clean messaging and interventions. If your challenge looks like it's leaning towards skills, or that confidence is limiting, then you're looking at the sociocognitive theory. And if the behavior is easy, but people forget it, avoid it, and you just want to make quick design tweaks, then you're looking at the EAST, right? There are different frameworks but there's a sort of my go-to and the more classical ones. And one rule of thumb is don't overmodel. You can just work with one primary framework, that can be enough. Or you can add a second, and I think I said this before, only if it changes your approach or if it changes your decision. Okay. I think that's like the overview introduction for this. And I wanted to just do something that's more practical to kind of sort of apply this in a to sort of walk you through how you can use some of this. Like I'll just use the combi because that's my go-to. That's like an easy one to use for if you don't know anything about the behavior and you really want to just diagnose it. And so um, I want to walk through like how to define your behavior, how to list your barriers and enablers, and then checking whether your barriers and enablers are listed at all levels and not just individual levels. So step one here is to define the actor. Who is the actor? What is the action? Where, when, and how often? And I think I've said this before, and I'm using that hypertension screening uptake that I've talked about. Say we want to get overweight and obese men who are 30 years or older to get hypertension screening at least once a month at their local clinic. The first step here is we have to define who we are targeting. In this case, we are targeting overweight and obese men who are 30 years and above. You can, or we want to target another group. You can be targeting pregnant women. You can be targeting men in workplaces. And then what exactly are we asking them to do? Your behavior has to be very specific. Are we asking them to get a blood pressure check? Are we asking them to accept screening when it is offered? Are we asking them to return for follow-up, where the screening will happen? And where should this happen? Are you targeting doing this at a clinic? Are you targeting at a workplace, in outreach? Where exactly do you want the behavior to happen? And then when or how often? Is it once every month, once every 6 months, during routine visits? Is it like a once-off campaign? So your behavior has to be very specific and it has to have all those, the what, the where, the when, and the how often. In this example, you can notice how we know what. We know who, it's men who are obese and overweight. We know what, it is to get screened. We know where, it is at a local clinic, and we know how often, which is once a month. So that level of clarity matters because it makes the behavior measurable and it helps us design solutions that match the actual real situation. After defining the behavior, then once we have that behavior really defined, the next step is this is where you can have your theory come in. And in this case, we are using the combi, right? And we want to try and list we want to list the barriers and enablers. Again, we are looking at we are listing them on capability, opportunity, and motivation. And the goal in this case is to get overweight and obese men who are 30 plus years old to get hypertension screening at least once a month at their local clinic. This is the behavior we want to try and change. So you can use this sort of worksheet to list capabilities, opportunities, and motivation. You are listing you can do barriers and enablers. And I want to try and do this in real time. I don't know if you can just, for any of this, you can choose capability or motivation or opportunity. And in the chart, list either a barrier or an opportunity and or motivation for getting men who are 30 years or older to get hypertension screening at least once a month at their local clinic. I don't know if that's clear. Just so we can, I don't know if I can open the chart. I don't know if someone is monitoring the chart, but I want to try to get us to use this worksheet in real time, so we can have some concrete ways of what I'm saying. The target behavior is to get overweight and obese men who are 30 years or older to get hypertension screening at least once a month. And in the chart, you can drop either a capability, something around knowledge. What do you think might influence whether these men would do this? Is it what do people know? Is it their skills, the know-how? And an example of what that looks like. What access or social factors exist? What beliefs, emotions, or habits can drive that action? So want to try and do this in real time in the chat. Let me see if I can open the chat.
I can read them as they come along if you like.
Okay.
I'm sorry, Abby.
You go ahead, Jay. You go ahead.
I am monitoring the chat for you.
Okay.
So no
Thank
worries. But I just want to be a little bit clear about what you're asking the participants to write in the chat. Are you asking them to list a barrier to men getting a screening? If you could explain that just a little bit for me.
Yes. So it can be whatever, when they think about getting men in that demographic to go in and get their blood pressure checked at least once a month at their local clinic. What could be a barrier that might be, stopping men from doing that? They can list it in either of these, either a capability, a knowledge, or a skill, or if it's an environmental access issue or a belief or intention issue. So it could be something like, I just don't know it's a risk to me. That's a barrier, right? That's a knowledge issue. I just don't know it's a risk to me here. And they can list in it, they can choose whatever they want to, whatever box they feel comfortable.
Okay, thank you. We do have a few comments. We have some barriers here. And guys, you can continue to just add them to the chat. So we have a barrier, getting time off work could be a barrier. Too busy for an appointment. Someone said no transportation or no time off from work, or afraid of a bad diagnosis. Very good. They feel well and no time. So they're giving some great barriers there.
Yep. Those are great examples. I was just trying to avoid my voice all the time and get some input, just so we can have like concrete ways of using this worksheet, right? So I think I had some of these in the chart. There's an example of how you can use this and fill out this worksheet. So barriers, it could be low awareness. I feel fine. Why should I go for a screening? I feel fine. It's not a problem. Or it could be unclear how or where to get screened. There could also be provider skills gaps in counseling. The providers just don't recommend or ask men in this demographic to come and do this. Another barrier could be long wait times or inconvenient. I think I had that. Or people just don't have beefy cup, blood pressure cuffs available to them, or they're broken. I have it available, it's broken, so I'm not going to do it. It could be a cost or transportation barrier that, going to my local clinic every month to get a screening is too much. I don't have the money to do that, or it's just, I don't have the time. I had fear of diagnosis. That's true. If I get a hypertension diagnosis, now I have to get on the medication, the cost associated with that. Also low perceived severity that, oh, well, my blood pressure might be slightly elevated, but that's not a big deal. It's common in my family. Everyone in my family has some type of elevated blood pressure. It's not, or screening is not common among men. It's just not something that men do. The flip side of that is the enablers. What kinds of things would get men in that demographic to do it? It could be like education sessions by health workers, or a simple what to expect clinic script. Like if you go, you should come in and this is what you expect when you get there to get your screening, or job aids for providers to be able to provide that. It could also be like just, instead of asking people to go in every month, can have a screening day in places where people frequent, or pop-ups where people frequent, or reliable supplies. People can, just track their own blood pressure at home if they have the supplies. or positive norm messaging, where people like you do this, or trusted messenger, where people they trust or that they look up to provide this message, or gain framed benefits, like what do you gain from this screening? It can avoid like long-term issues, you get treated early, and you benefit in this way. So this is an example of how the COM-B diagnostic worksheet can work. It sort of forces you to look at the bigger picture. You're just not focusing on raising awareness, but you're trying to look at it from different perspective. And you also want to not stop at individual level. The final step is sort of this quick quality check, because sometimes without even realizing, you can tend to just focus on the individual level. So this using sort of this metrics can allow you to, or force you to ask if the barriers and enablers that you are thinking of are happening at the individual level, are they happening at the social level, or are they happening at the structural level? And this is important because if the problem is a structural problem, and then your campaign is at an individual level, then you won't solve it. So you want to use this bias check to make sure that you are not missing key social or structural determinants that might be important for addressing that specific behavior. So going back to like our example of getting men, what was it? We're trying to get men who are 30 years or older to get a hypertension screening at least once a month. Going back to that example, we have some of these that we have listed. The next step would be to try and think about how do they come in at these different levels. So we make sure that we list them at the different levels, and we don't miss, or we don't just focus on the individual, but we focus on multiple layers. So I'm just going to show what it might look like when you look at it from all those levels, right? So from an individual level, you know, we can have people not knowing that hypertension can be silent. We talked about this. They don't know when or when. We talked about this. They don't understand what the blood pressure number mean or what high blood pressure can imply. At the social level, it could be that family and friends can spread misinformation, or the people that they trust can spread misinformation, or, you know, blood pressure check is only for older people, or community beliefs can downplay risk, or conflicting advice from peers, right? Where some might be pushing home remedies versus screening or clinical care. At the structural level, you might have the providers not trained. You might have lack of job aids, and then a weak referral pathway. You can go in and get screened, and then the staff don't, you know what to do with you. Is there a clear referral pathway for you once you get certain blood pressure numbers? And the same, you can have the same for opportunity at the different levels. People can, you know, at the individual level, it can be a time constraint. At the social level, it can be that, you know, the people around them don't encourage them or provide practical support, or workplace or community routines don't, you know, make room for this type of screening or this type of behavior, or social norms will discourage it. And then the structural, you go in to the clinic, and then the blood pressure cuffs are not available, or things are not working, or it's service constraints, it's limited access points. The same for motivation. You have individual level barriers, you have social level, the stigma, or maybe some masculinity or identity norms around that. You can have low trust in services at the structural level, or, you know, perceived system failures. You know, even if I go there, they are not going to do. If they go there, they tell me that my blood pressure numbers are elevated, they're not going to do anything. Or the fear of financial the financial outcome of a diagnosis. So in summary, if you are going to diagnose your problem, you want to start with naming your behavior. Who is the actor? What's the action? Where and when and how often? And then use your theory. In this case, we use the COM-B to kind of map out or understand the problem. We use the COM-B to do the barriers and enablers first. And then sometimes you can have a lot and you cannot focus on all of them. You want to list the most important ones in your context and keep items specific. What can be the most important ones? And then use this as a sort of a bias check, the metrics as a bias check to make sure that you don't just focus on the individual, but you are also doing social and structural determinants as well. And like I said on point 2, it's important that to be very focused. You cannot address everything. You don't have the time, the money, the resources in most cases to be able to address everything. And I just wanted to check in, like for our just a pause for our problem. What might be a promising area to focus on improving hypertension in your specific context? Just this is a very hypothetical example that we're trying to get the men who are overweight or obese to go in for that screening. From this discussion, what might be a promising area to focus on? Just drop something in the chat. I'm going to pull back up to this and be like, in your context or your, what might be a promising area or level barrier to focus on to be able to change, to get these hypothetical men in for this blood pressure screening every month.
One more time, Dadi. What is the question?
I'm just asking like what feels doable out of like looking at these barriers, what can be something that's easy to focus on or easy to address? If we're trying to get men in the room, if you're trying to get men who are overweight and obese to get screening every month at their local clinic. I think I see in the chat screening in the workplace rather than getting them to come to the clinic. Yeah, that's one thing. So that's addressing the time, the constraint. What something else that might be doable?
Well, I guess it might go hand in hand with screening in the workplace, but also maybe mobile screening. I know we have some things like that where it could be, a van or a bus that maybe comes to you, mobile screening at different community centers or something like that. Make sure that we notice that that it's free, advertise it in a way.
Yeah. I'm getting some more examples in the chat. You can have home monitoring, blood pressure machines, simple digital blood pressure machines are available now that you can provide and people can just do it at home. Or you can have blood pressure screenings, stations in community centers that people frequent, community outreach in homes or towns, pop-up clinics, or have a focused clinic and reduce wait time. So these are all great examples and they address different levels, like having blood pressure cuffs that people can do at home. I can address some individual level constraints, what was the community outreach in hometowns, pop-up clinics, blood pressure screening stations in community centers can address like access issues. So that's like sort of examples of how you can start to think through how you can design your campaign based off of like using this COM-B worksheet. Okay, so moving on, we have now diagnosed the problem. We've used the COM-B to diagnose the problem, right? We looked at the barriers, we looked at the enablers of the problem. Sorry, is my screen still showing?
Yes, it is.
Okay. It looked like I had stopped sharing for a minute, so I just wanted to check. Okay. So now we have done the hard part, right? We now know what the problem is. We know who we are targeting. We know what we are targeting. And that means, we're not guessing anymore. After we've used that, we are not guessing. We're not jumping straight into a solution. We know what the problem is, we have diagnosed it, and now we move to the fun part, which is designing the campaign or the intervention, right? So in the next section, we are going to try and take that thread of taking what we've learned from that combi and turn it into a practical health campaign, right? Health promotion campaign to try and design an intervention. And quick check before you start, you will need to capture if you captured at least one social determinant, if you capture at least a structural determinant and the single biggest bottleneck, right? So you would look at that and you want to prioritize. Is it a capability issue? Is it an opportunity issue? Is it a motivation issue? What's the biggest bottleneck in the context? And then with that, you can start, this is where you revisit this metrics, and then you try to really prioritize, in my context, what really is the biggest bottleneck. And then you focus on that in the design. So for your design, they are like sort of 6 building blocks, right? The first is you have to know your audience. And I think we talked a little bit about that. You want to know the behavior objective. What is the action you want to target? You want to know the key barriers, which is what we got from that combi diagnosis. And then you want to know what the message is. What will resonate? What framing should I use? And then what channel should I use for this health promotion? Where will my target audience see it? And then you want to do a small test and have indicators, how you can learn quickly what's working and what's not before you roll out a big campaign. So using that hypertension screening example, right? Your audience, you can have this as men 35 to 55. These are informal workers with limited time. They have low perceived risk. The objective is to get their blood pressure checked once a month at a convenient point. It can be a clinic, market, mobile clinic. What are the barriers? Say, for example, your biggest was like the low risk of perception. People just don't think, this is a big issue for them. Or it could be a time, cost or opportunity, or a fear of diagnosis. And then your messaging can be BP is like blood pressure is silent, check every 1 month, or protect your family, know your blood pressure numbers. You want and then channels, is it a market day outreach? Is it like a WhatsApp messages that you send? Is it like a community health reminder? And then you can do a small test. You can pilot 2 messages at 2 sites for 2 weeks, and then you can track those and update reasons for refusal or reasons for lack of uptake, right? And just to zone in a little bit and think about that audience. The first step is defining that audience. You want to, when you're building a behavior change communication strategy or like a behavior change campaign, you want to be as specific as possible when you're building your persona, right? So you can create a very detailed picture of the target person, right? When you think about it, you want to think of a person, like a specific person. This is the person we want to target. What is their age? What is their role? What is their context? What do they care about? What are their values? What are their priorities? What gets in their way? That's when you are looking at those combi barriers. And what might help? Who are the trusted messages or convenience, right? And you have your behavioral objective. I think we've talked about this. You have your behavior objective very clear, who you are targeting and what you want them to do. And this is an example of a persona where you can have your persona. This is someone named John, who is 43, who is an informal trader. He has busy mornings, and he has been to clinics and experienced very long wait times. He cares about providing for his family and staying strong for his family. He thinks he feels fine, so he has a low risk of perception, and he's really afraid that if he's diagnosed, life changes and there's going to be a lot of health costs that are associated with that. He goes to church a lot, so he trusts church leaders, community health workers, and friends who are screened. And the best way to reach John is market days or quick on-site screening. So your behavior objective will be, how do I get John to go in? And having a very detailed persona, I think it helps to really zone in and think about those barriers. What really affects, what do they care about? That can help you with those motivations. So you want to think about these personas as comprehensively as possible, and put in anything that you can think about your target person or your target population. So your intervention or your campaign can be effective. And then when you move on to messages, you want to, you know the person that you want to target, and then your campaign is starting to take shape. You want to think about that message. And you want to design a message that matches the barriers that you identify. And messages that typically work include like a gain framing. You can frame your messages as a gain. Like if you know your blood pressure numbers, it helps you save in future medical costs because you catch this problem earlier and you can address it before it becomes a big problem. Loss framing, cost of waiting. If you wait long, this becomes a bigger issue than it was. Social norms, people like me are screening. So you want to craft your behavior, your messaging to touch that, male your age are doing this. Identity, strong parents check their blood pressure. So you are looking at someone who is a parent, who is very proud to be a parent and cares about that. And you want to have your message touch on that. You can choose 1 to 2 messages. You don't want to overload your audience. And then think about your channels. We talked about this and I think channels is very important because you want to choose where the audience actually is, not where you wish they are or where is convenient for your campaign. Because sometimes, it's convenient to just, do something at the clinic or do something at an outreach day, but maybe your target person is not coming there, or your target audience is not going to be in those spaces. So you want to really map out your when you do your persona, right? When you think about the person that you want to target, you really want to think about where do these people frequent and how do I get my message to reach them. And it can be any different channel. And the rule of thumb there is to match the channel to the barrier. If it's time, bring the screening to them. If it's whatever it is, right? So you don't want to use a channel that's not addressing those key barriers that you have unlocked. And then once you have your message, you can pick 2 messages that you think, 1 or 2 messaging that are punchy and will drive the point home, and then you can test those. Fast testing to make sure that it's actually working. And it's a very key principle in behavior change to do a small test before you scale. So instead of just like spending money, resources in launching one big campaign, you can pick a very small setting and run a quick comparison. So for example, you can campaign a gain framed message to a norm framed message to see what actually moves within your context. So if you're going to do things around, knowing your blood pressure, will help you, stay healthier longer, or people around me are testing what works to get people to actually take up the behavior. And you can also test channels. You can test, sending people messaging on WhatsApp or other voice or other messaging platforms that are common in your context, as opposed to like reminders at clinics or reminders at community outreach centers or something like that. What actually works, and then you compare those. The goal is not to have perfect message, but the goal is to see what is likely to have better traction in getting people to adopt the behavior. So you can test message A versus B, or site A versus site B, and then have key indicators that are going to capture which message was clearer, which message really motivated or led to more uptake, and what people said when they refused or ignored a certain message. And then you can use that for a second round of like the combi diagnosis. Like, okay, you can say when people were not, people who didn't take this up, this is what they said, and then you can refine those messages. I think behavior change is also very iterative. You test things, you change, you tweak, you test, you change, you tweak, until you get something that can get people to take behaviors. And then finally, we also want to keep track of what's working and what's not. So you want to have indicators that are simple, that are measurable, and that are time bound, right? You want to make sure that you can look at different metrics, right? You can look at uptake. What is the number of people who have been screened, or percentage screened by month or week? You can see if your numbers are going up weekly or monthly. You look at reach, the number of people that are being exposed to these messages, what's the attendance at the local clinic. You can look at conversion, the percentage who are exposed to the messaging, who actually went for screening. Or you can look at quality, the percentage who received screening, who received counseling or referral. And then uptake by age, by location, by social status, right? That's looking at equity. And then you can look at learning. What are the top 3 reasons for not screening? You can have like a quick exit survey that captures that. So this is like a whole, list of different indicators. You can look at what your campaign objectives are, and a few indicators that you can zone in on that can be quick to inform. And depending on also your learning objectives, you can zone in on different pieces of this, and you can have a few indicators. Sorry, you can have a few indicators for each of these different dimensions. So you can refine different pieces of the campaign. And like I said, your indicators need to be specific, they need to be measurable, and they need to be time bound, right? For example, you can have an indicator that's looking at increasing blood pressure checks at clinics among men who are 35 to 55 from X percentage to X percentage in 4 weeks, right? I think this is the quick exit where you can ask people, what are the main reasons you did or didn't get your blood pressure checked today? Is it time, fear, cost, didn't know, they felt fine, or other? And then you can use this for your next combi iteration. So this is like your 1-page campaign sort of worksheet or canvas that you can use. Again, behavioral objective, who is your audience, what are your top combi barriers, what are your 2 message options, framing that you want to use, what are the channel mix, and what is the small test and primary indicator that you can use. So this is like you can use this as a quick and dirty way of like designing your campaign, or your campaign in a single shot. This would be your full campaign in a single shot. I don't know if you have questions, clarifications at this point. because I want to move into like trying to do this in real time. I don't know how well we can do that, but if there are any questions in the chat, please let me know. I'm not monitoring the chat, so if there are any questions, let me know. But for this next session, I want to see if, just try and do this practically and apply this and try and design an actual campaign, right? We can think about a behavior a behavior that you care about personally or in your setting or in your work area. It can be anything from diet, physical activity, changing school meals, breastfeeding, hypertension, anemia prevention, vaccine uptake, whatever behavior you want to focus on. Then try and think of your primary audience for that and try and write one behavior objective and try and do a quick and dirty combi analysis where you can say, okay, these are the barriers and enablers, and then think of a message and a small test, right? And we want to make sure that it's realistic in the setting. Are we matching channels to barriers? Are we can the uptake be measurable in a short space of time? So I'm going to go through a few slides to walk us through this, right? So the first is we want to try and complete this canvas for a design. Like we want to have a behavior objective. We want to have your message. You want to have your small test. Starting off with the combi. So for a behavior of your choice that you are thinking of, think of, who is the target person for that behavior and what can be like the objective for that. And I put a few examples here. Like in this case, if it can be parents of children under 5 and you want to increase healthy snacks at schools from 3 times a week to 5 times a week in 1 month. Or you are targeting workplace managers because you want to offer weekly blood pressure checks for staff for a 6-week period. This can be any behavior, any NCD related behavior of your choice. The next thing is doing that combi worksheet for that target audience. What can be like the barriers? Is it knowledge, skills? What are some of the opportunities, resources, environment, social norms that can affect uptake of that? What are some of the motivation, beliefs, emotions, or habits that can affect uptake? And I put a few examples on screen for, yeah. It could be that, under opportunity, unhealthy options are cheap. That's like a cost of healthy options. It could be the barrier. It could be healthy food doesn't taste good, which is a belief. And then under capability, it can be unsure what a healthy swap is. So if you're going to target people swapping certain snacks with healthier ones, they could be just knowledge that they don't know what the healthy swap looks like. And you can try map this out for your chosen behavior or NCD outcome. And then two campaign messages. You can have a messaging that's looking at attention, emotion, or social proof, or a message that's looking at practical what to do, right? Strong hearts start with small choices, that's sort of attention or emotion or something like that. Or message 2, which can be swap 1 sugary drink for water today and start this week. You can try for your chosen behavior to think of what messaging could look like. And then for channels, what could be a channel that you can use for your specific behavior? It can be, 2 to 3 channels where the audience actually is, and what a 2 week small test can look like. 1 or 2 indicators that you can measure within a week, what channels you can use, 2 week test, indicators that you can use. For example, percentage reporting swapping, or a 2 week test, you can have a healthy swap challenge where you say for the next 2 weeks, we are just testing whether people can swap like high fat, high sugar snacks for healthier options. And you can do this through like a messaging portal, like a messaging platform, or through posters or reminders or things like that. So yeah, those were just like prompts for you to think through something, a behavior or something that you care about, and try to think about what that might look like, right? To fill out this campaign canvas or template. So I did this for addressing healthy diets in school-age children. So your behavior objective and audience can be, I want to increase the percentage of children who are between the ages of 5 and 13 eating at least 1 fruit and 1 vegetable during the school day, from a baseline percentage. In this case, maybe the baseline percentage is like one day where they do this, to at least 4 days a week. Sorry, I don't know what happened there. Within 8 weeks. And I want to also be specific on who does what. So the children, in this case, will choose the fruit and veg. The caregivers pick this. And then schools can make fruit and vegetables more available or more visible to students. And then messaging, I can, have a message that says, fuel your brain, brighten your day, fruits and vegetables make you stronger in class. This is an emotional or identity related message, or you can have an action oriented message. Add 1 fruit or 1 vegetable to your school day. Examples that you can add include bananas plus a tomato slice, or apple and a carrot, or orange and a cucumber. Channels, you can use school assembly or classroom reminders, posters, or you can have like peer student leaders who can promote this. Small test, you can have a fruit and veg challenge for 2 weeks where each child aims for 1 fruit during school day. And then you can have daily prompts. And then you can have your specific indicators. This is an example of, how you can think of or like design a campaign. And I'm going to pause for a little bit and give people, if anyone wants to share how from the prompts, thinking about the behavior that you had, an example of how you might approach a behavior, like how you might approach this campaign. I don't know, anyone who wants to mute and share, to unmute, sorry, and share. Maybe no one wants to be on the spot. Okay, that's fine. I can move on to the next, but maybe if people have questions or want me to go over anything else in terms of how to think through designing a campaign before I move on to a few more slides. If we don't have questions, I can move on to advocacy, which is shifting gears to advocacy. I think the important idea about thinking about advocacy is just that it's also behavior change that's just aimed at decision makers. So I hear talking. Is that a question or? Okay. maybe not. I was going to say, so for advocacy, it's still behavior change, but it's just behavior change that's aimed at decision makers. And we want to start by defining who needs to act, what action we want them to do by and by when. Then we can do a stakeholder mapping, who is the primary decision maker, who influences them, who might block the change, and who can influence this to happen. We can also select, we need to have a very clear story that can move them, or evidence that can move people who make decisions to make decisions. And then a timing, when is the window of opportunity, and a call to action, which is what exactly we can ask for. So you can also definitely do like a combi mapping of advocacy to map out like what can be a barrier to having decision makers take up a specific policy, and design and use the same key steps actually to design an advocacy that you can use to design a behavior change health campaign. And I went back to the hypertension screening example that we've been using for the presentation. You can have a policy targeting district health officers or facility managers to ask them to approve monthly mobile screening outreaches at work sites. And you might want to have evidence, right, that shows why this is important. We just, like some research evidence that shows that screening helps, and it detects silent blood pressure and help reduces like hypertension complications. And you can have like a key story, like a narrative story that can complement that evidence. And then who is the messenger? Who should deliver this message? It can be clinic nurses, community leaders, or local champions. Timing, you can align it with monthly planning for decision makers or upcoming budget cycles. You want to provide the message when there's opportunity to act. It's the same principle of behavior change, that you want to provide the messaging or when people can still act on it. And you want to have a very specific call to action. You want to have it like, do this outreach plan by allocating staff or blood pressure cuffs by a specific date. It needs to be actionable. It needs to be measurable. So this is an example advocacy, worksheet where you need to have your advocacy objective. Be it a policy, is it a budget, is it a guideline? Who are you targeting? Who are those decision makers you are targeting? Who is delivering that? That evidence or the narrative story that can help move the timing, the window. Who do you, what window can this happen? And then call to action. This is your exact ask that you want them to do. It has to be something that's actionable. So this is sort of a worksheet you can use to plan like your advocacy plan. And just to show an example of this advocacy plan in action, so objective or budget, it could be, if I go back to that school feeding, we want to improve healthy diets among school-age children. Your objective could be you want to adopt and fund a healthy school food policy that requires daily access to affordable fruits and vegetables, and sets some minimum nutrition standards for school canteens, and limits sort of high fat or sugar and salt snacks and sugary drink sales. So the target or the policy target or key stakeholder, these are the people who have the ability to move or make the decision. And it depends on at what level you want this advocacy. It could be all the way to the Ministry of Education or School Health and Nutrition Unit, or it could be at the level of school boards where, you just want them to push out a specific school policy around specific schools. And your key stakeholders, you want to map them out. And then messengers who deliver, it could be a joint Ministry of Education and Ministry of Health team who supports that. And then the narrative, you need to have that evidence, the research that supports this. And then window, when do you need this to happen? And then a call to action. By end of this term, you want to approve this is an example, by end of this term, approve a pilot directive in 10 schools that require that schools require tuck shops to offer at least 2 fruits or vegetable options at a low cost price point, or implement a healthy combo rule where you're supposed to do fruit and vegetable plus water option with monitoring once a month. The key here, like I said before, is to think of advocacy as a behavior change strategy that's just targeted at decision makers. I don't know if we have questions. If not, I will wrap it up with an ethics sort of checklist. I think behavior change should never be about manipulation. So I think it's important that you ground your behavior change campaigns or advocacy within behavior change ethics. It should it should be about designing programs that respect people and reduce barriers. It's important to maintain autonomy and informed choices by supporting agency, not to manipulate or coerce people into specific behaviors, right? You should be transparent, being honest about intent, not widening gaps by reaching only to specific groups. It's important to think about who could be left out, what barriers remain, and then think about non-stigma messaging by avoiding shame, blame, or stereotyping. When you think about, those norms or messaging, or what your message should say, it should avoid blame, it should avoid stereotyping, and should not blame individuals who might fail to take up certain behaviors. There should be privacy. I think in this digital era, it's important to think about, what channels you use and what privacy you need to keep, like what standards you need to keep to maintain data privacy, consent, how to securely store things, and then safe participation of vulnerable groups, as well as, anchoring everything within cultures. It's important that you have it be culturally relevant to the language norms and local realities of your target audience. I don't think it's a separate step. It's something that should be built in from when you are diagnosing your behavior, designing and testing your campaigns. You should have like ethics be a thread that is that you think about through all those steps. I think with that's about it with my slides. I will take questions, comments, or inputs. I don't know if people can still hear me.
Yes, we can still hear you.
Okay. I don't know if there are questions, inputs, or if you want me to go over anything again.
Okay, well, I do have like a quick question. Something that stuck out to me on your list of ethics was around coercion, and I guess in a sense, sometimes, we do try to be very persuasive. So I'm guessing what is the line between kind of like being persuasive, coercing, and like, what's kind of the ethical principle around that? Because like if we take sometimes we try to say, okay, let's do what industry does, and industry is very manipulative and very very much coercing people to eat unhealthy foods. And so we're saying, okay, well, let's do the same as industry. So what's your thought on that? Like in terms of like the line between persuasion and coercion or,
I think it's one of those delicate dances that you have to, because it's very important to think through, the objective, because like you say, we have people are bombarded with messaging from different sources and different places. Like industry, as you're saying, is very manipulative in that. And I don't know if it's useful or like long term for long term behavior uptake to manipulate people, coerce people into specific behaviors. I don't know if I can clearly say this is the line. I think that's something that is very context and like topic dependent. And that's something that you have to like, I think the very final point on that slide was like cultural relevance and local realities. I think that's something that you have to ground in what's acceptable locally. Because some messaging, and I think in some campaigns that I've also worked on, some messaging was like questionable, but it was acceptable from the pilot testing and that we had done. So I don't have a very good answer for you in that, because behaviors are very hard to change. Yeah,
okay, no problem. No, okay, but it's good to get your input and I appreciate the answer. Thank you so much.
no worries. I think someone in the chat said, will it be possible to get slides later? I think if I can certainly share my slides and they can be shared with people registered.
Thank you.
I don't know if we have any more questions, comments. If not, I think I will hand it back over to, is it Jay?
Yes, Dadi. Thank you so much. We definitely appreciate you coming on tonight. And before you wrap up, we do have in the chat a survey link that our students have created. So if you guys would take a few moments to go into the chat and fill out the survey, so our students can get all of the information that they need to continue with their practicum. But I'm thankful that all of you have showed up tonight after work. So a sincere thank you to you, Dr. Daddy, for sharing your time and your expertise and insight this evening. Your work in behavior change and health communication is incredibly, incredibly valuable. And we appreciate you just being part of the discussion tonight. Second, I'd like to thank the students, Alexandra and Chrisanne, who played a major role in bringing this webinar together, from planning and coordination and all the outreach and promotion. They put in a lot of effort, and we just appreciate you guys for coming on and doing that with us here. Thank you to everyone that came tonight and joined us, and just for being a part of the discussion for strengthening health promotion and NCD advocacy in our communities. We hope that you leave with practical ideas that you can apply in your own work and in your own spaces. And on behalf of Lake Health and Wellbeing, I am Jay Robinson, the project assistant. Ms. Abby Beho, our founder. We thank you again for your time and participation. We look forward to continuing this conversation. So before you log off again, if you just take a few moments to fill out the survey, and thank you all for joining us this evening.